55-year-old lady, diabetic for a long period of time, difficulty in walking, a very unstable ankle, and she had this non-healing ulcer on the lateral side of the ankle because she was weight bearing on that for a period of time. And this is the kind of X-ray picture she had, and you can see how this talus, that's where the wound was, and she has been doing this. So here you can see for people who are on web, that's she's been weight bearing on that, and that's what she had a non-healing ulcer. Now how do you manage this ankle and this lady? So the key thing, the alignment, the key goals for patients with Charcot, and especially of the hindfoot Charcot, is to restore the alignment stability of the foot, to make it more braceable, plantigrade and stable. So we are not looking at a bony fusion, we are looking at a stable hindfoot. That's what our aim is. Definitely we know the fact that patients whom you should not be attempting to reconstruct where there is an active infection of soft tissue or bone, like this lady who came from I think Nigeria or Egypt with a fulminating infection on the bottom of the foot. Fixation in acute phase, Dr. Petrova has already mentioned it. You should be very well aware of what is happening in the acute phase, though there are some papers coming out that you could fix them in acute phase as well, but not for the hail-hearty. The uncontrolled diabetic, peripheral vascular disease, and I think this topic we will talk in the discussion. Patients with Charcot, what is the blood circulation? Because the normal thing is, I think patients who have good circulation will develop Charcot. Patients who have peripheral vascular disease probably don't develop Charcot. But we'll talk in the panel discussion. And insufficient bone stock and patients who do not comply to your instructions, I think those are almost contraindications for attempting hindfoot reconstruction. So dilemma, so why so much talk on reconstructive surgeries in Charcot? Because these are high-risk patients, multiple comorbidities, there are technical difficulties, and of course you need a multidisciplinary approach and a team to manage these patients, which may or may not be available in their centers. But these should be attempted because these patients, if you start with a single amputation, invariably they may go to the other side as well and may end up with a bilateral amputation, and the energy expenditure. If you have a patient with bilateral amputation, you are literally getting this patient to either wheelchair bound or house bound. So that's why we try to save the limb as much as possible. Now if you do a reconstructive surgery, especially looking at a fusion, the fusion should be in neutral or slight dorsiflexion in the sagittal plane, should be in slight calcaneum valgus around 5 degrees, not more, and a bit of external rotation in the transverse plane. Do not do it in equinus, that's almost a no-no. So what are the options? We've heard about from Dr. Petrova, cast is a very good option in early phase, and especially if there is no or minimal deformity. Usually people have been considering external fixate or Elizaro as a hallmark for Charcot, but you have these two other options. You can have an internal or an external, a nail or an iron rod and a plates and screws as an internal fixation. But before we go ahead and do some surgeries, you need to make sure you take care of the ulcers. And ulcers, you need to define or differentiate between infective ulcers and non-infective ulcers. So those are the two things which you really need to know before you go ahead and do some internal fixation. And by treatment of ulcers, you need to relieve the pressures, especially the bony pressure which is there. Restoration of skin perfusion if you're suspecting any issues with the circulation. Metabolic control, especially HbA1c, should be very well controlled, and adequate wound care, which we have already heard. Cast, we have already heard from Dr. Petrova, good option in the initial stage. And even if the patient comes with a really bad, like this patient of mine who had very bad Charcot, hindfoot Charcot, but you can put them in a cast and let the swelling settle down. And what happens, you look at this is 2 years follow-up, patient treated purely by conservative treatment. Over a period of time, the swelling reduces, hindfoot becomes stable, and you form new bone formation. Of course, these patients, even initially they are treated by cast, they have been told that they may require surgery in the future. What other next option is either a hindfoot nail or a Elizaro. That's the most common discussion happening. How do you treat them? So this is a paper in 2016, 27 cases, 60, almost equal number, 16 in nail and 11 in Elizaro. Almost a follow-up between 2 to 4 years. And here you can make out limb salvage was equally good, 9 out of 11 versus 15 out of 16. So limb salvage was equal in both groups, but deep infection was more common in the IM group. 7 patients required removal of the implant, and finally they concluded that the need for revision surgery was higher in the IM group compared to the Ilizaro group. Another paper in 2017 comparing both same Ilizaro versus IM nail, equal numbers, 27 patients, 14 versus 13, and they found that the complication rate was significantly greater in the external fixator group than the internal fixation. So yes, limb salvage can be done in both groups. The key thing is in the Ilizaro group, what I find is the expertise is required and patient compliance is the key thing. Internal fixation can be used, and there are different variable plates available, anterior plates, lateral plates and posterior plates. Unfortunately, we don't have those specialized plates available in India, but you can be using the Indian jugaad and can use a proximal shoulder plates, the Philos plates, and use it in a reverse manner. IM nail, you can do it in supine position, lateral position or a prone position. But before you plan nailing, you need to be aware of what has the patient got, previous incisions, previous hardwares are done or not, do you need a plastic surgeon or you need an interventional radiologist, amount of bone loss and anticipated hardware. Approaches, you can do a dead lateral approach, or you could do an anterior and a sinus tarsi approach if there is no significant bone loss. In the nails, there are 2 types of nails usually available. You have the straight nail, which is easy to use, you don't need a excessive valgus, and you have a curved nail, which reduces the damage to the neurovascular structure at the calcaneum tuberosity and gets a better bone anchorage. Now the key discussion, a lot of people, especially non-foot and ankle, do you really need to prepare the subtalar joint? Evidence suggests there is a 23% incidence of non-union, and initially when I started doing this, I didn't prepare the subtalar joints, and look at this patient had a distal tibia fracture, everything went well, but the nail broke at the subtalar. So you should prepare the subtalar joint. I'm not going to go through this video, it's available for sake of time. So my case series in the last 6 years, I've been doing 60 Charcots, 32 males and 26 females. 22 patients had Charcot of the foot, 17 patients managed by internal fixation of the foot, midfoot. 37 patients had Charcot of the ankle joint, 8 patients have bumpectomy, 9 Charcot fixation for non-healing ulcers, and 36 went on to do a TTC nail. So these are the kind of spectrum of cases of mine. Here you can see the talus which was almost out. Here you have a decent bone stock. Here the calcaneum is completely eroded and the talus is literally sitting on the floor. Here there's hardly any bone to play with, and here you can see the talus coming out. So these are the spectrum of cases. So initially when they come with a non-infective ulcer, I just debride them and put in a fixator, let them heal up, and once you will be surprised, once you stabilize by a fixator, within 4 to 6 weeks these sinuses just heal up completely. Now case which I had shown you, discussed earlier, put in an external fixator, debrided, put in a fixator, waited for some time, and then did a hindfoot nail. That's the nail. She's been doing very well. That's a movement still achieved. People think there is a completely the foot becomes rigid. No, they still have some movements. And this is the video where she is walking around and very stable and very happy lady. And she's not a small lady. She's a big, heavy lady, but she's been very happy. Another patient, hindfoot, in going in valgus. This is not this side, this one, and this is the pre-op, post-op. You can see here the calcaneum is completely lost, tail is sitting on the floor. So I use the fibula, lift up the hindfoot and increase the hindfoot. I believe that hindfoot height should be reconstructed because that gives a mechanical advantage. Here I have used a curved nail. And he walks almost 10 kilometers a day. I almost tell them, do not walk barefoot, please make sure they get some sort of orthotics. So results follow-up ranges from almost 6 months to almost 4 to 5 years. I've achieved almost bone or fibrous union in most of these cases. And ulcers heals in most of the cases managed by external fixator. Of course, I had my share of problems, 3 cases of late infection which required removal of the implants almost by 6 to 9 months. But by that time there is fibrous union, plantigrade and braceable foot. Intraoperatively, this I did not pick it up in my early days, and here you can see I had a perioperative fracture. The key is to recognize that intraop, of course, if not, at least I put them in a cast and make sure that they are protected for at least 6 months. Another case of broken drill bit, this is the talocalcaneum screw which goes in one of the company's nail, the drill got broken. And another case, especially the same type of screw, because it's literally at the edge of the calcaneum, you can bypass the nail and you just get an outside fixation. So just be aware of what is happening perioperatively. So in short, my protocol of Charcot is, what I divided are the open Charcot or closed Charcot. If it's an open Charcot, I put them in an external fixator, wait for 6 to 8 weeks till the wound heals, make it into a closed. And once it is closed, as I said, the aim is to achieve a stable and plantigrade foot. And then you divide. If it is ankle, you do a hindfoot nail or a plate, and if it is midfoot, plates or screws or a combination. So in Charcot, modern techniques of internal fixation has changed the course of these kind of patients. Of course, they need to be definitely counseled that they will need a prolonged immobilization, which helps in the union rate and decrease the complication rate. Thank you very much.